Good afternoon, everybody. Welcome to Global Health Conversations at Brown University School of Public Health. It is our great pleasure today to have Dr. Fernando Alarid Escudero, who is an assistant professor at CIDE, which is the Center for Research and Teaching in Economics in Mexico. He has a PhD from the University of Minnesota in health decision sciences, and is an expert in statistical and mathematical modeling. He has previously been awarded a master's in economics from CIDE and a bachelor's in science in biomedical engineering. He has a long list of accolades already, including being an elected trustee of the Social for Medical Decision Making and being twice winner of the Social Medical Decision Making Prize in Quantitative Methods and Theoretical Developments, a Fulbright scholarship for his doctoral degree, among other things. So it's our pleasure to have you here today, Fernando. Very briefly, before you start, if you allow me 1 minute, I would like to make a plug for the next Global Health Conversation, which will happen in January 26th at noon. We will have Mandla Majola from South Africa, who's a health researcher and activist. And in terms of housekeeping, Fernando has agreed to do his presentation, but he doesn't mind being interrupted. So if anybody has a question, please put it in the chat, or if you'd like to come on video, he'll be happy to have it interactive. He'll present for about 45 minutes, and then we'll open up for questions and answers. Without further ado, please, Fernando, the floor is yours.
Thank you, Omar, and thank you, IHI, for the invitation. It's a pleasure for me being here and to present the work that I've been conducting on COVID for the past few months. So I will start sharing my screen. And again, as Omar mentioned, please feel free to ask any questions if you feel you would like to ask them by any time. So let me share my screen. All right. Well, looks like it's sharing already. So I'll present an evaluation of COVID-19 mitigation strategies in Mexico City. I'll use a mathematical model approach to this health policy analysis. And I'm speaking on behalf of the collaboration with the Stanford CIDE Coronavirus Simulation Modeling Consortium. And I don't have any conflicts of interest to declare. I also would like to thank the funding agencies that have supported our work throughout these past months. And also acknowledge the contribution to all the SC-COSMO consortium, which has been a tremendous and productive experience working with all of them, both at Stanford and CIDE. So as well, you probably already have your fair amount of COVID-19 information. So I'll give you a little bit of context of what is happening in Mexico for those of you that are not aware of COVID-19 situation in Mexico. So as late November, Mexico has the 10th highest incidence confirmed cases of COVID-19 worldwide, and the second number in Latin America, right behind Brazil. And its case fatality ratio is 11.1%. That is more than 1 in 10 confirmed cases die or have died in Mexico. Mexico City metropolitan area, which is not only Mexico City, is the one of the most populated cities in the world. And so I'll be focusing my analysis on Mexico City metropolitan area, which is Mexico City and its surrounding metropolitan area, which is of nearly 20 million people living in MCMA and contributes to 22% of the country's GDP. So it's just one area, is a small land area, relatively speaking, to Mexico, contributes to more than 1/5 of its economy. So it's quite relevant in terms of geographically, economically, and socially. MCMA has the highest, is as expected, not only number of cases, but also incidence of COVID-19 cases in Mexico. And here's the age distribution of cases over time. I'm showing the left panel, the number of cases, And on the right-hand side, I am showing you guys the incidence rate per 100,000. As you'll see there, we have like a concentrated mass towards ages 20 to 59. So we have this concentration of the epidemic has remained relatively stable. But once we account for the population structure, we are seeing that it has shifted a little bit towards the younger ages over time. In terms of CFR for Mexico City metropolitan area, is also high, one of the highest. It's below average, but still quite high, like 10.5% by late November. On the left-hand side, I have the number of cases over time. And once we account for population structure by age, we see that we're getting older ages are being hit harder. I mean, we are also doing some specific analysis with a relative survival to try to extract what is the actual contribution on mortality from COVID. That's not part of what I'll present today, but to try to extract out what's the contribution of age to mortality and see whether there are some differential reasons why older people are getting hit harder. NPIs or non-pharmaceutical interventions are currently the primary reason of controlling the COVID-19 epidemic, pretty much like all over the world. But NPI, especially when focused on business and school closures, are highly disruptive to economic and social well-being. So it is very important to counterbalance these concerns. Because what we try to do is try to reduce the amount of people getting to the hospital at a certain time and then threatening the functioning of such healthcare system. With incidents rising rapidly across Mexico and in Mexico City metropolitan area specifically, the existence and strictness of NPIs are highly policy relevant. So we are collaborating directly with decision makers in Mexico. We started collaborating by first giving them guidance on how to construct their own mathematical models for projection to try to do early projections of the epidemic and make decisions on whether they will remain closed or how strict the NPI should be implemented. So on March 23rd, there was a national NPI set in place that it was pretty much a hard NPI that everything had, like non-essential workers would have to stay at home and all the rest of the businesses should be closed by then. So this national NPI lasted until June 1st, where the government officials started relaxing these NPIs. And as policymakers consider proposals to resume in-person schooling and permit other business-related activities in the near future, we provided estimates quite in real time. We sometimes had like weekly projections or bi-weekly, and especially at the beginning, they were more interested in what things could happen. So we're still working closely with the officials in Mexico City. And what we did is combine primary data analysis with simulation modeling to evaluate different NPI scenarios to say, what if they started relaxing certain businesses or certain venues, and when, and the strength or strictness of this implementation of NPIs or relaxation. So they were interested in seeing all these results, and they're continuously interested in this. So our aims for the project that I'll present today is to estimate the effects of relaxing current NPIs on COVID-19 cases, deaths, and hospitalizations in Mexico City metropolitan area. And we'll consider relaxing current social distancing in both workplaces and resuming in-person school activities specifically. I'll give a broad overview of the SC-COSMO models. It started as just one epidemiological community model, but now it has grown in more different types of models or sub-models or sub-modules as well. For more detail on the epidemiological and household model, you can guys see it in our website. So as I mentioned, SC-COSMO stands for City Coronavirus Simulation Modeling Consortium. It's a collection of epidemiological, intervention, and resource utilization modules, and uses most up-to-date scientific evidence on the SARS-CoV-2, the virus, and also the disease that it causes, which is COVID-19. And it's fed by setting specific open data on the COVID-19 epidemic. We have already adapted this suite of models to various countries, states, and municipalities and counties. For Mexico, we have adapted this model for all the states in Mexico, which are 32 states. And we have an extra model, which is the one that we're presenting today for Mexico City metropolitan area, combining places not only from one state, but for multiple that create this metropolitan area. For the state of California, we have created county-specific model. And so we are able to project the epidemic, but at a lower level for the whole state. And also we developed a microsimulation model of the epidemic in the California state prisons, specifically for all the prisons managed by the California Department of Correctional and Rehabilitation, often also known as CDCR. The idea with the SC-COSMO modeling suite of SC-COSMO suite of models is to create a dynamic real-time decision-making system where we have real-time data being generated on the epidemic. We use that data, synthesize, and put it inside the model for the model to be able to project or predict what could potentially happen on the different scenarios or give guidance on what's the dynamic of the epidemic. And based on that, decision makers take that information and make decisions on whether they want to continue implementing NPIs or implement different NPIs, relaxing or modifying current NPIs. And that's what we've been working with several states in Mexico for doing this. And also my colleague, Jeremy Goldhaber in California has been leading the effort working directly with California Department of Public Health. So let's start first with a community model. The community model is like this so-called SEIR, which is the susceptible, exposed, infected, recovered. And also we have the S, which is susceptible again, that allows for individuals to lose immunity once they get infected and recovered. And it's a multi-compartment, both for the exposed and infectious states that allow for non-exponential distributed dwell times. So we know if the time to exiting these exposed and infectious does not follow a constant rate, then we can increase the number of compartments to then make this time to leave or time to exiting these disease states to make it an Erlang or gamma distributions. So we calculate what should be the number of these multi-compartments to fit the cumulative distributions of latent and incubation periods. We also track the illness of severity, which is related to outcomes, but also to the likelihood of diagnosis. So we have a low severity and high severity. So low severity is denoted by blue and high severity is denoted by pink. And also each of these levels of severity could have a differentiated detection rate based whether you do symptom-based detection or also allows for places where they've considered or will plan on considering a screen-based detection. This is just like a list of the system of differential equations, which I'm not gonna go through them. So they are stratified by level of severity, age, and also detection. I think more relevant is the force of infection. The force of infection, which is the rate at which susceptible individuals acquire the infection, is age dependent and is also venue dependent. You can see it here just as a term called lambda, or the Greek letter called lambda. But in fact, this is a little bit more complex how it is structured because it is venue specific and it also determines on detection status and whether detected individuals are more likely to stay at home, and so its infectiousness will decrease. And the venue specific, the different age specific contacts or contacts between different people of different ages is governed by this so-called who acquires infection from whom matrices, which are also venue specific. We estimate these venue specific WIFE matrices for subnational areas using only publicly available data. There's this publication where the colleagues from London School of Hygiene and Tropical Medicine and other, basically that's where Mark Chitt, who is the senior author of this publication, in 2017, they published this WIFE or contact or mixing matrices for I believe 152 countries Mexico and the US included in this, as well as other countries like Brazil, which we also implemented this model in Brazil, so we use this data as well. But they do it as at a national level. So what we do, we propose a method or develop a method where we take this national level density, contact matrices, and we apply a regression approach to estimates of national contact matrices. And this estimation of the county-specific or state-specific mixing matrices is determined by the population density or adjusted population density. I'm not going to go into more detail, but happy to talk more about this. I have slides that describe the method, but I based on the time that I have to present, I'm happy to talk in more detail if you guys are interested later on. But applying this this method, we're able to calculate mixing matrices for all the counties in the US and also all the states and municipalities in Mexico. But for Mexico, because we don't work with county level models, only state specific, we do state specific mixing matrices, also venue specific for them. But here, this is the ones that we have done it for all the US potential interest. If you guys want to model different counties in different places and want to take this national level adapted to either state or county specific. And here I'm just showing.
Can I ask a question? Could you tell us what the measurement was there? Was that number of contacts per individual, or what is the measure here?
Yeah, so the contact matrix is number of effective contacts that individuals have within a day.
Within a day.
Between different groups of ages, between different age groups. So let's say an individual who is like 10 years old, let me here, how many contacts that individual will have with other people of different age groups in a given day. And because it's venue specific, we have the number of effective contacts in schools, in workplaces, at home, and other places. I think there's 4 different venues or stratifications that they have in the paper.
Thank you.
And it's important to, you're welcome, it's important to put attention on the word effective number of contacts, because what we call an effective number, an effective contact is a contact that if a susceptible is in contact with an infectious individual, that contact could potentially lead to an infection on the susceptible individual. It can have multiple ways in which they interact, but accounting for the effectiveness of this contact, that's how they computed these measures. So that was a just brief overview of the community model, but we also developed a household model, and which we also presented at the SMDM last month, or I guess 2 months ago. And why a household model? Most of compartmental infectious disease ordinary differential equation models rarely separate household transmission from community transmission. However, the pace of household transmission may differ from community transmission and depends on household size and can accelerate epidemic growth. And also the effects of NPIs might be heterogeneous between non-households and household contacts. That's when we realized where just having a community model was not enough, and our projections were not that accurate because we were overestimating what would the effect be of NPIs. And also we found that the household secondary attack rate is often higher than community-based transmission. So just to give an example, we have a community where we have susceptible individuals denoted in black and infected individuals denoted in red. So individuals will infect infectious individuals will infect susceptibles at a rate beta, given the amount of contact these individuals have. And then we have a household, let's say a household of size 4, where we have, again, 2 individuals within the household that are susceptibles and 2 individuals that are infectious. That infectious can also transmit at a different rate, in this case tau, that we found that attack rate is higher than in the community. And there could be a cross transmission from the community to the household. So when we evaluate an NPI, the NPI is meant to reduce transmission in the community and transmission from the community to household. However, there's quite some evidence that these MPIs will not reduce the transmission within household. Why? Because let's say you stay at home, and once you stay at home, you continue interacting with the same family members or the same household members in the same way as you did before. You can think of, oh, well, maybe they will even interact more, but there's some evidence, and I have, which is part of the regression-based approach of estimating county level mixing matrices, where the density of the population or the number of, the density of the population or how much time they spend on household does not increase transmission as much. Why? Because there's at some point you saturate your number of contacts. So let's say in a regular day, you have 15 effective contacts with the rest of your members in the household. If you stay 8 hours a day, there's not going to be any more difference if you stay 24, because you've already saturated this maximum amount of contacts that could lead to a infection once in susceptible and infectious individuals interact within the household. So what we did is we expanded a simple susceptible infected recovery model that tracks household and non-household transmission proposed by House and Killing in 2004. And we took this model and expanded it to include a multi-compartment CIRS structure, allowing for non-exponentially distributed times for both the exposed and infectious compartments. This has been like the toughest task that we've done as a group, because once you incorporate these non-exponential dwell times, the model needs to because the model keeps track of the proportion of household and the counts of individuals in each of the household in each of the states. So once we account for these movements, especially from within this exposed and infectiousness, then you have to implement convolution of binomials for the transition matrices within the different states. So that has been one of the most challenging modeling methods that we have to tackle in the past few months. And personally has been the model that has taken more time for me to build and debug. And I also have like a collection of slides on this if you guys are interested on some of the details of this household model. And we also have the more described in more detail in our website. But what we find when we account and not account for having a household transmission is that in populations with larger household size and for diseases with non-exponentially distributed infectious durations, epidemic dynamics are faster and more intense. Why? Because the bigger the household, let's say everybody stays at home, but if they stay at home, there's one infected, even though their social distance is high in the community, but within the household, then it's gonna burn faster that epidemic inside the household. So if we don't account for this, then we say, okay, the epidemic is gonna move at a lower rate than in fact it could potentially move, given that households are bigger than, well, are big, like let's say 4 or more. This was what we actually found in both Mexico, but especially India. We did a bit of work in India for the first 4 months of the epidemic. And our projections by not using the household model were not as accurate. So once we incorporate this household and the household size of the different places in India, then we're able to get more accurate projections of the epidemic. Also, accounting for realistic within household context accelerates epidemic and increases its peak. So the peak can be higher once we account for this transmission. And it is also magnified with non-exponential infectious and exposed dwell times. We also have a hospitalization model. The hospitalization model takes positive or cases who are hospitalized, and some fraction of these cases will ultimately have more severe illness than others. And this gets reflected on the severity of illness or requiring a ventilator. In Mexico, depending on the setting, but specifically in Mexico, we focus on those that require a ventilator and those that do not require a ventilator. And depending on the severity or the need of a ventilator, their length of stay might be different. So for this, we developed this soft module, which takes once the individuals get detected, and then there's a likelihood of them being hospitalized. And once they get hospitalized, they account for non-exponentially distributed times, which is basically we're modeling as a time inhomogeneous or time-dependent Markov model. Parameter estimation. A lot of the data comes from both epidemiological data from the virus, specifically incubation and latent period. Also hospitalization, we have the times that individuals spend in the hospital. And for some states, we actually have a super detailed information on how they transition through the healthcare system. And for that, we actually build a multi-state model, which is this generalization of survival models where we account the time, and this is like a parametric multi-state model. So the more detailed information we have, we are able to better characterize the dynamics of these patients through the healthcare system. But specifically for the Mexico City metropolitan area, we don't have that level of detail. We only have when individuals get hospitalized and when they either get discharged or die. We don't know how likely or when they move from non-ventilator to ventilator, and sometimes they go from ventilator and then they are discharged from ventilator or the same hospitalization. We don't have the level of information. But at least we can compute the length of stay from the day they get hospitalized and when the day they get either discharged or die. But for the more epidemiological parameters related to transmission, which is a community transmission rate beta and a household transmission rate tau, also we calibrate the rate of detection, and this rate of detection is time dependent. And for this, we use a generalized logit functional form for detection over time. And for that, we have 4 parameters, which is the initial bound, the first bound and the final bound. What's the midpoint at which the logit is going to go from low to high or high to low, depending. And also the rate at which is going to go from one of the bound to the next. So there are 4 parameters there. And also estimate the level of effectiveness of MPIs in reduction of the effective number of contacts. So we have a period where we have the epidemic prior to the MPIs being in place, which is from, let's say, February 20th all the way to March 23rd. And March 23rd is when the MPI got implemented. So we have some period that we know how the epidemic was growing freely, let's say. And then we know when the MPIs have got implemented and what was the rate at which, when did the population start changing its dynamics, specifically its mobility, which is a proxy for us to model a number of contacts. So we can account, we use piecewise models to detect what is the point at which the individuals are going to change their behavior. And we found that there's like 5 points in time that it has happened. So estimate when is the time, and then we impose a change on the level of contacts at that time, and we estimate what is the level of reduction or movement of the effective number of contacts at that day. We estimate these 11 parameters using a Bayesian approach, using specifically the incremental mixture importance sampling algorithm. We use uniform priors based on previous knowledge, because we've done this calibration multiple times. We do it, we used to do it weekly, now we do it 2 or every 3 weeks. So now we know where the parameter space is better suited. So we now inform those priors based on what we found in the past. As calibration targets, we only calibrate the community and household model on cases. Those are only calibration targets. And we assume that the cases follow a negative binomial likelihood. And the results that I will show today, we are using the last day of calibration is November 3rd.
There is one question, sorry, Fernando, there's one question from a member of the audience. It says, detection rates relate to testing rate?
Yeah, that's a good point. Detection rate is what is the like or the probability that a detectable individual, that is someone that if you test that individual and is infected and you test, then that person could be detected, which is different than testing rate. Testing rate is the amount of tests implemented in the population. So let's say you have a population of 100 people, and then you apply 10 tests then you have a 10% testing rate. But detection rate is individuals that are detectable. What is the rate at which they're going to get detected? And once we estimate that, we can also back calculate the total proportion of population at a given time that is infected and detectable. So that's what I mean by detection rate, the rate at which detectable individuals can get detected. It's also informed, we use information on testing rate because, of course, the more tests are in the population, this detection rate will increase, although the relationship is not a one-to-one, but it's informed because we can know when the testing behavior starts changing over time. Thank you, Omar. To estimate the points at which mobility changes, which we use mobility as a proxy of change in effective number of contacts, we use Google Mobility. We started using from February 2nd to, in this case, the last day we used was October 20th for both Mexico City and State of Mexico. And we use a piecewise linear model with multiple change points to approximate the mobility trajectories. And for each state, we estimated 5 change points. This differs based on the state, even country, county, or state where you are refocused. Some states have changed their behavior at less points in time. Some others, like they've changed it more times over time. So specifically for Mexico City and the State of Mexico, which are those places that is mostly populate Mexico City metropolitan area, there's been 5 change points. And we use the mean value of those change points to generate the overall Mexico City metropolitan area. To give you guys an example, this is how the change points look for both Mexico City and State of Mexico for different places. So we have, you've probably seen this data, but we have from grocery and pharmacy, parks, residential, retail and recreation, transit and workplaces. So it's interesting that for once we see a big change right before the national policy was implemented, which is around March 16th, because that's where there was all these worrisome in Mexico that the epidemic had already hit and they started to see community transmission. So people started self-isolating at the time before the NPI that was March 23rd was implemented. So we see that the people started self-isolating right before or reduce their mobility. And then we estimate where would be the points at which the trend will change. And here on the left-hand side, we have those points denoted by vertical dashed lines for Mexico City. And on the right-hand side, we have for the State of Mexico. So we take the average between those and then use that for the Mexico City metropolitan area. To do uncertainty propagation, we sample 1,000 parameter sets from the joint posterior distribution from the IMIS algorithm. And then to compare the outputs of the calibrated model against the calibration targets, we propagated the uncertainty of the calibrated parameters of the SC-COSMO models. And then we compute the 95% posterior predicted interval as a measure of prediction uncertainty. And we take the range between the 2.5 and 97.5 percentiles of the model predicted posterior outputs. For data, we use the time series of individual level cases on both cumulative and incident for Mexico City metropolitan area, and the source is the epidemiology department of the Ministry of Health. They release every day all the cases for all Mexico by even either municipality or county level. And we also use time series of hospitalization occupancy. So we know what's the level of occupancy of hospitals in Mexico City metropolitan area and we get that information, which is daily updated by the Digital Innovation Agency of Mexico City and also the National Epidemiological Surveillance System of Mexico City. For demographic data, we use total population size, population age structure, age-specific background mortality, and then components to calculate the adjusted population density, because the adjusted population density is what we use to transform the country level mixing matrices to state specific. So we use the total land area, urban land area, and the fraction of the population living in urban areas. And for that, we use the office data from the Office for National Statistics. I'll present outcomes on time series of incident and cumulative cases, and as well as deaths, and also hospitalization occupancy with ventilator and without ventilator. The different policies that we simulate are relaxation of social distancing on January 10th of 2021. And the reason is because the school semester is supposed to start on January 11th. So we say, what would happen if they in fact allow individuals to go back to school or the kids to go back to school on January 11th? We implemented those, and we have two scenarios on resuming school. One is what would happen if we resume school, assuming the level of contacts prior to the epidemic. Let's say that kids would not use face masks, they wouldn't use like gel and whatnot. But a more realistic is we assume that if they go back to school, they will have the same level of reduction of contacts as what you would see in the community. So they will still have the same level of hygiene, of distancing that you observe in the community, which is what we observe is more realistic. And also we evaluated reducing social distancing in workplaces by 50% of what we observed. If so far we've seen a 50% reduction in contacts, we'll reduce that 50% by 50%. So at the end, we'll have 25% reduction. And we project outcomes from November 4th all the way to the end of February, which is February 28th of next year. So I'll show quickly what the prior and posterior distributions look like. And we have here the 11 parameters that we calibrate. The ETAs are the level of reduction on the social contacts. And we see that there's been an increase. It's probably like not a nice way to show, but ETA 1 is the level of social contacts, or like the effectiveness, let's say, of the national MPI, which was implemented in March 23rd. So we see that around 50%, there was a reduction on March 23rd of 50% of the total effective number of contacts in the population. Then we have ETA 2, which they continued decreasing this because the way we use it is a multiplier. So we even observe a higher decrease in social contacts. But then recently, which is ETA 5, has been a relaxation of this social distancing, which that's kind of like what we were expecting. People started getting into like going to work. Schools still have been not implemented in person, but a lot of jobs and different commerces have already opened, and people have started to interact more. We found that beta was around, given an effective number of contact, the probability of infecting an infectious individual asusceptible is around 18%. And we see that for the household, on average, if we take the expected value of this posterior distribution, it would be around 27%. So this is also consistent with what we found in our secondary attack rate meta-analysis, that it was around 1.5 times what we see in the household than what we estimate in the community. We did not impose this relationship, so there's no multipliers or whatnot that on the household transmission is X times the community. So we let the parameters be completely free, and then verify that what we find is consistent with the literature, the previous literature, and our previous estimates on an evidence synthesis that we conducted earlier on. This is just like some parameters are extremely correlated, and we have some issues of non-identifiability. We found what are the level of this non-identifiability. We know what are the parameters that are extremely correlated, and this has helped us to then be able to account on how we're going to deal with this uncertainty propagation, which is why we decided to go with Bayesian as well. We started doing some maximum likelihood-based estimates, but given the amount of correlation, then to really propagate the uncertainty, we saw that using a Bayesian approach was the most appropriate. Here I'm showing some of the projections. So here's the estimate the actual data is denoted in red dots or red circles, and the model predicted outcomes in incident cases is depicted by green. So the mean projection is the line, the solid line, and then we have this ribbon, which is the uncertainty on the projections. This is just on the status quo, assuming that the level of reduction on social contacts that we estimate by November 3rd will remain that same level all across until February 28th. We also projected number of cumulative cases, and we see that it could be quite wide, our amount of estimated cases. And but I think more interesting is what would happen if we implement these different policies. So if we resume schools with estimated social distancing, that is, if we resume schools with the same level of social distancing that we estimate and we see in the community, we can see an increase around 2% of cases by the end of March compared to not opening schools. But if they resume schools and there's no that carefulness of social distancing within schools, it can go up to 5% increase by end of February. And if we resume schools and also reduce social distancing in workplaces, and it was an important policy I forgot to mention, because governmental workers are still working from home. So there's an interest of making them go back to work in person, whether that's something attainable. But we see that there's like a significant increase, significant, not like statistically, but saying like meaningful of at least 20%, or the estimated increase will be 20%, but it could be up to 45% increase in cases if they allow these workers to go back to work in person. We estimated cumulative deaths, and we are for Mexico City metropolitan area, we are expecting that if same amount of social distancing remains, getting 40,000 deaths by the end of February. Just to put in context, for Mexico right now is around 110,000 deaths, and so we will be getting up to 40,000 just in Mexico City metropolitan area by the end of February.
Fernando, we have another question, excuse me, from the audience. It says, apologies if I missed this. Was there any accounting for potential unobserved heterogeneity among the individuals being modeled?
Well, the heterogeneity that we take into consideration right now is age. I don't know if that's answered the question, or Haesung, if you have because I can now see the question in the chat. If you have a more specific question on what type of heterogeneity, I'm happy to answer that. But so far, at least for the population, we just stratify by age. There's no other stratification rather than age.
Okay, thanks.
Yeah. So we found that if we continue with estimated social distancing, we have 45,000 deaths, and ranging from 32,000 to 78,000. By resuming school with estimated social distancing, we'll get an increased amount of 2,000 deaths based on status quo. And if we resume schools without social distancing, it will go up to 51,000 deaths. And relaxing social distancing by 50% and opening schools, will get up to 64,000 deaths on expectation by the end of February. I think one of the policy variables that they're more interested in, which is not only for Mexico City, but I guess in a lot of places all over the world, is hospitalizations. So occupancy on, if we continue with social distancing, because we're expecting to peak on, let's say, first week of January, then by February 28th, we'll see a decrease of hospitalizations. But given the amount of uncertainty, we might expect an oversaturation over the next few months, which hasn't happened yet, fortunately. And resume schools with estimated social distancing in the community is an important result, because it might be that capacity might not be reached in the period that we observe. So this is something that we know that as long as we allow people to interact more, reducing social distancing, we know that the number of cases are going to increase, number of deaths are going to increase. At least in Mexico, there hasn't been a strong policy that can allow for reduction of this amount of fatality, at least. So we know that we expect that, but the problem is whether it's still going to be manageable. And why is the reason? Because there's still a huge amount of population that is susceptible, that is waiting to get infected as soon as they start interacting with infectious individuals. So there's still a big mass. So we're estimating that by now, at most 50% of Mexico has been infected. So that means that there's still 85% of the population that can still get infected. So once they go out and start interacting, then we'll have a big mass of population getting infected. So that's why relaxing social distancing will, no matter what, increase the amount of infectiousness or infected individuals. So the question is, can we allow in-person schools? Because there are trade-offs associated to that. Especially in Mexico, the different schooling system is having a tremendous challenge on serving different type of populations to provide education at home. A lot of the kids don't have access to a computer or a tablet. So sometimes it's by phone or even WhatsApp. So we don't want to get this delay on the kids getting their education. There's some other colleagues that see estimating what could potentially be the loss in human capital by just pretty much having one whole year lost in these kids of not pretty much learning what they were supposed to learn, and some others trying to translate that with the potential economic losses in the long term. So that's why they are very interested if they can allow getting back to schools, but also allow making sure that they will be able to maintain this level of hygiene and social distancing. And resuming school without social distancing is not an option. That's why it's super important that the Ministry of Education works directly with the ADIP, which is the Agency of Digital Innovation, is the agency that is in charge of implementing these NPIs in Mexico City. So it is important. So that's kind of like the message there, that if they're going to resume schools, they have to make sure that they will follow all these different regulations on the NPIs. And then I have with ventilator, of course, the number of people who require ventilator is less than the total amount of hospitalizations. And this is the one that is of more concern for state officials, because of the amount of ventilators. They might have the beds, but they might not have as many ventilators available. And we have on status quo getting up to 1,100 by the end of the projection date, and 1,700 if schools are resumed with social distancing, and up to 3,300 on expectation if resuming schools without social distancing. So I know we're getting close to the end, so I just have one more slide, which is the conclusion, and I kind of like walk you guys through that conclusion, that relaxing current NPIs implies a drastic increase in incident cases, which inevitably, the key, I think, what we found is that if school is going to resume, it's important to make sure that they apply the same level of social distancing, if not even higher social distancing, and perhaps with kids, it could potentially be achievable to have a higher increase or a higher reduction, let's say, in social distancing within school, and that will allow as well for kids to go back to school. But definitely reducing the amount of social distancing at workplaces or letting people go back to work in person, that's definitely still not a good idea. So I think I'll end there, and thank you very much again for the invitation, Omar, and all the colleagues at IHI and everyone that joined the seminar today. So please let me know if you have any questions, or shoot me an email if there's anything else you would like to know in more detail later on.
Thank you so much, Fernando. That was a great overview of what we know is a very complex model. One thing that I think many of us are interested, because we're at School of Public Health, is sort of the so what. And I know because of our other conversations that there is a lot of interest in this, but could you just say and share a little bit about the reception of this model and how the government in Mexico City, especially, Claudia Sheinbaum, who's the chief of government there, and her cabinet have just share a little bit about how you've interacted with them. I think the audience would be interested in hearing that.
Sure. So we got contacted quite early on in the epidemic. I remember we started working this on early March, and I got contacted by them. I know exactly that day, on March 21st. I received a call from one of a person in her cabinet asking for guidance on how to build these models. They are very technically mind-driven, applied mathematicians and economists, but they didn't have experience building epidemiological models. So they asked for advice, and we spent several hours on the phone on, like giving some guidance. The references, for example, the book by Killing and Rouhani, which has been tremendously useful for us, at least, and I guess for other modelers out there. So we gave them these references, how to do parameter estimation, what they meant, and how the minimal level of stratification for a model to be useful, at least on the early periods of the pandemic. So we started building trust by that. We were not consulting for them. It was just like literally at this point, the next thing, at least within the consortium, SC-COSMO, is like, if we have something, we produce something, let's just put it out or have a conversation with whoever needs it to try to do this a transfer of knowledge and technology. So for us was, let's just work together, because at that time we were working very closely with the government of Brazil. And so we had this commitment with them. So we could not like shift gears immediately to start helping Mexico City at the time, but say, we can help you guys. And they were interested. Claudia Sheinbaum was very interested in building their own model. So by having this interaction early on with this guidance on how they could build their model, it built this trust with the group. So they started trusting us, and we also started trusting them. And we had these meetings early on how they could use the model, what modifications they could add to keep track of hospitalizations that are with their model. There was a point at which the level of complexity was not enough to model everything that was going on, changes in mobility, social contact, and that's what they asked us if we could use our model to then help them do projections. And since then they say, whatever you guys need, and it's something that is attainable for us to get to you, we can do that, and then just help us whatever you need, whatever we need to learn or answer. If you guys can provide us projections for that. So that's what we've been doing. And then later on, we got awarded a grant by SMDM to get funded to support this work, because all this requires a huge amount of analyst time and very technically driven and smart people working on this to do all these parameter estimation projections. So for that, you need to get the funds from somewhere. So fortunately, we got the grant, and then we're able to support this work. And we continue doing that with them.
That's great. I think there's time for maybe one quick question, if anybody else has anything.
I have a question, if I may. Thank you for a really, really great talk and really impressive model. I wanted to ask a broad question, which is you settled on a compartmental model, and I wonder if you considered an agent-based model. Why you came down on this on the side of a compartmental model, and what you may have gained or lost as a result. Could you think that through with us?
Yeah, for sure. That's a great question, Mark. And I just stopped sharing, so perhaps it's nicer to look at each other face to face. I don't know if that's better or not, but if you guys want to see any slide, I can share again. So the reason why we use decided for a differential equation model was because if I don't know how this word to say in English, but how parsimonious it could be. So it depended on the amount of complexity. It was we decided early on that an agent-based model was at the time was not needed because we didn't want to model a lot of complexity, a lot of stratification. And the reason is to do specifically parameter estimation and projections. Our original model was taking less than a second to run. Then as time went by, we said, okay, let's keep building more complexity to the model. And that's where we reach a point which, have we known now how complex it was going to be to merge with a household model? Because we had not done it before. We knew about these household models and play or develop some like relatively simple ones. But the household model was a tipping point where we say, this is a challenge, and both my colleagues and I are, excited about this methodological challenge. Okay, this is a challenge, so let's do it and solve it. It took us several, like even hundreds of hours to build the household model and integrate with a community model. And at the time, it took us that long that perhaps a program in agent-based model would have been faster and more efficient. But now that we have the community coupled with a household model, it runs significantly faster than how long it would take to run an agent-based model. So it still pay off to still have this differential equation model. Because now we can do all these Bayesian estimation. I mean, we use it with distributed computing. So we use Amazon Web Services and also some servers to do parallel computing on the Bayesian estimation, but still is significantly faster than what an agent-based model would be. We did build an agent-based model for the prison epidemics because for that we also had a more detailed data that we can inform mixing where and when each of the inmates are, with whom they have contact, when do they work, in what they work, their ages, comorbidities. So we build this agent-based model for prisons. And because this is more localized, it's also easier to use that. But also for the community, we could have built a more complicated or complex, let's say more complex and detailed agent-based model, but it's also difficult to get all the parameters to really characterize accurately that level of detail. So that's why we decided to keep the differential equation model for the community in general and household as well.
Okay, thank you very much. We are at the hour, so we will end the formal presentation. If you have time, Fernando, if you can stay for a few more minutes. I know that there may be some additional technical questions that Tom and perhaps others want to ask. I certainly have a couple more if you have time.
Yeah, for sure. I have time.
Okay, so let's just stay a few more minutes, and whoever wants to stay, please stay. But obviously, we have reached the end. And thank you, everybody, for coming. And thank you, Fernando, for a great talk. One quick
thank
question.
You. I see the comments on the chat. So thank you guys for your very nice comments. Appreciate it.
One quick question that I had is your comment on the mobility and the tau parameter, the household transmission rate is interesting, because I would think that the NPI is not as effective on the tau, and how you thought about that. That's one. And the other one is that I didn't see you mentioning the R, the reproductive number anywhere. And if you obviously probably have it somewhere, but could you just share that, and what are you getting?
Yep. So for the first question is, why do we kind of like came up with like splitting beta and tau? It's exactly because we were seeing, based on literature, that NPIs will most likely not alter transmission within households. And by not having that in the model, we thought that there was a problem that we'll eventually face. So we started working early on to see how we will going to take into consideration that to split this transmission, especially because the strategy will make people stay at home. So then a lot of the dynamic is going to happen inside the household or within the household, let's say. So by not splitting this transmission, we thought that eventually we have a problem. So that's why we split, and then we saw the work by House and Keeling mentioning that there's could be a potential meaningful difference in the epidemic timing and the size of the epidemic. So we saw that this could also be relevant for us. So that's why we initially built a simple model, SEIR, and then we saw, okay, yeah, it looks like it's going to be a different, and then we devoted the time to expand for the multi-compartment nature, which was the one that was challenging. And then how you compare, once you have the multi-compartment household model, which is not, that one is not age structure, how do you pair it with a community model that is age structure? And that was another challenge. And then we had one member in our group interested in the household secondary attack rate, and she started doing all this literature synthesis, and it was consistent that the household attack rate was higher than in the community. So that's why we said we needed to model this. And the nice thing is it's just like a comment of a lot of things we did not know how to do, but it was like you face a challenge, then you have to figure out how to solve it. So that's been like very rewarding, but sometimes, I don't know, methods can take years to develop or thinking, but here they had to be done in weeks or months at most. So that's been also like a challenging, but also rewarding that eventually you get to solve the problem. And on the reproductive number, the effective reproductive number, because it is a complex model, it does not, I mean, it could potentially have an analytical solution using the next generation matrix, but given the amount of differential equations creating that matrix, we have not done. There was some interest with on an applied mathematician on doing it, but I guess it hasn't been as part of the to-do list for that person recently. But what we decided to do is you compute it numerically. So the different methods that could compute the effective reproduction number numerically. However, some of these numerical methods are quite computationally intensive. So for this presentation, I did not compute, but we do have a way to compute it if decision makers are interested. I think the relevant is they want to know at which point on for each of the strategy will bring the RT below 1 to see whether that's going to be an effective policy. But we are drafting the paper on this analysis, and on the paper we are going to compute that. It's just that computing that for one single run, computing the RT takes longer than actually running the model. So there's something that we are working on right now.
As you said, though, I mean, if you just take the infectious subsystem and through next generation matrix standard stuff, you would have an analytic solution, and then it's just a function, right?
Yeah, it's just that because the amount of ODEs is quite high to create the next generation matrix because of the level of certification. That's what we haven't spent time on.
Yeah, true, and you have to do an eigen decomposition, and
yeah.
Although all these matrices, well, I don't know how this one will look, but there's a lot of zeros, and it it could be that it's an easier thing than one might suspect, but yeah, it's going to be tedious. It's going to be tedious.
Yeah, that's why sometimes it's just a matter of finding the actual time to do some of these analyses. That's what, but the numerical method, I mean, you just plug in your results of the model and numerically compute it, but it's computationally demanding. But this is actually something that we're discussing this morning, Jeremy and I. This is the next thing we have to focus to speed this up. Either we take a week or however time we need to put together the next generation matrix, or find a more efficient or improve the numerical method for RT. But that's a great question, Omar. Thank you.
Looking forward to seeing that. There is one more question here. I think it's from Mark. Do you want me to read it, Mark?
Sure, go ahead.
Mark says, really interesting talk. Thanks so much. Another question, if you have time. In the US, congregate settings, especially long-term care homes for the elderly, account for a large proportion of transmission. Is this the case in Mexico? And if so, how did you account for that as compared to, say, the household model?
Yeah, so long-term care homes in Mexico are not as common as in the US. So the sociodemographic structure is a bit different. So elderly folks tend to live within the households and not in long-term care facilities. So the actual people that take care of older adults are family members. So that's why for us was not as relevant to incorporate and consider. However, for the US, there's also some interest. There was some conversation with some colleagues in Massachusetts. They were trying to do also like an agent-based model for long-term care facilities. But I can give you an example for what I would think could be done, because something that we do for prisons, because we have the prison workers. So prison workers live in the community. So what we do is we take the projections from the county-specific transmission or epidemic projections, and we assume that the workers are going to arrive with that characteristic from the community. So if we were interested in modeling long-term care homes, let's say I would build or propose building an agent-based model or microsimulation model long-term care facilities, and then we have the workers that are part of the community, and there's a likelihood for them to be infectious or infected, and perhaps not symptomatic or depending on how they could come from the community. But for Mexico, given that it's not as common as in the US, so we decided not to include that.
Fernando, one thing that has bothered us somewhat is the following: is that when you take back an NPI, there's no guarantee that it will have an effect that is opposite than what it had when it got first implemented, because we see that, you know, people learn. Another way to put it is, as you showed, there's good evidence that people started reacting to it before March 23rd, when whatever the first NPI was. And therefore, you know, when you learn the effects of NPIs, it's not really that NPI, it's that people started adopting a different behavior because they see what's going on in the world, right? They see that Italy didn't have enough coffins. So how, perhaps I missed that, but how were the NPIs parameterized? I mean, in our case, we gravitated away from parameterization of the NPIs. We started doing that, and it ended up being no better than just estimating an arbitrary dampening function that varies by day. That essentially says, you know, I don't care what the NPI is today. I'm estimating that in order to see this time series of cases, hospitalizations, and whatnot, you need a dampening function that looks like this, today, and so on. And you know, predictions in the long term are essentially done by parameterizing this dampening function to be some sort of an autoregressive business. So the difficulty with the NPI comes with the reopenings. If I estimate, for example, that there is an effect of something when I have a lockdown, or an effect of something when I have school closings, and even if I'm willing to assume that these are just a conditionally independent multiplicative effects, when I reopen the schools, it doesn't mean that it's going to be just, you know, putting that back in. Mm-hmm. So yeah. How have you been thinking about that? I mean, does it? How do, when you were doing your calculations that said I'm going to reopen schools, how does the effect of reopening schools happen?
Yeah. So first, like when I say the only NPI that we more or less fix is the one that happened on March 23rd. And we actually implemented earlier based on what we saw on the Google mobility data. That's the only place where we fix where is going to be a reduction in contacts, the place, based on that national NPI. But that later on, we don't say, even though we have a June 1st lifting of the national NPI, we don't impose an MPI lifting or modification on June 1st. What we do is we find what's based on mobility data, where we see a change in the trend, and based we say this piece like change point in the trend. That's where we implement where we should put a multiplier, which is a dampening on what would have happened.
Gotcha.
That's what we do.
Yeah. So essentially, it's
in the project.
Essentially, it's like this dampening function being a piecewise linear
exactly
thing on some scale, and so we gravitated away from piecewise linear functions because we saw that they were not actually you could have decent fit to the data, but if you have many time series, it's you can do better by just having functions that change every day.
So what we haven't, and I'll answer the question on the schools, but is if you have questions that change every day, so for example, how many parameters do you guys estimate on those functions?
So it's essentially like a random walk with some autoregressive components. So technically, it's one random variable per day for the dampening function. It is identifiable because it's governed by a structure from the autoregressive things. Okay. Look, we speak regularly, so we'll find an excuse to understand more. But there's another thing I want to get your reaction on when it comes to the nursing data stuff. Sorry, the nursing home staff and the congregate care in general, right? Prison and so on. Because of exactly the idea that you put forward is that these people do not mix generally with the population, but it's really that they soak in infections based on the people who travel there and work there and live in the community. What we realized early on is that it was beneficial to actually model the population, the non-congregate care population, with compartmental models, and have an add-on set of statistical models that are, time series type of models that actually describe what happens in the congregate care population. And for future predictions, you use the predictions of the model in the non-congregate care to feed into what would happen in the congregate care. So it's kind of like a mix of a compartmental model and a set of statistical models. And this has worked decently well for us. So that, could be another way, instead of actually doing an agent-based model for the congregate care, do a set of statistical models.
It's a lot faster than agent-based model.
Right.
Yeah. So the reason why we had to build the well, we are not working, as I mentioned, on long-term care facilities, but for the prisons, we did have to. We decided to build a micro-sim model because we are able to then. What happens if you block a yard or a building or a dorm? And so for that, it was more like the focus was on the prison, so we can model pretty much any intervention we want, like testing, who's going to get tested. We have information on race, sex, age. And we coupled the ODE with the micro-sim, specifically just for the workers we are getting what infectiousness. But I guess
I follow what you're saying, and Jonah is building, such a micro-simulation model for agent-based model for nursing home, a thing that very much doing the same rationale as you said.
Yeah, and then going back, Tom, to your question on schools. Then the way we assume is first, just very naive, is we on that day we reactivate, let's say, school contacts, and we say let's reactivate in the same level of contacts that they had before the epidemic. But this is a naive one, just to show for comparisons. But we don't think that's going to happen because people learn, and we know that now folks are going to wear masks and whatnot. So what we do is we reopen, but the same amount of dampening that we estimate in the community.
Mhm.
And then the other would be, what if we are stricter at schools? And then we can use that strictness to say, okay, if you reopen schools in the same amount of context as in the, or dampening that is in the community, they may still be not ideal, but we have to be even stricter. So how much stricter we need to be, relatively speaking. So that's how we model the schools. Right?
No, well, that's reasonable. That's very reasonable. So
Yeah.
you know, just as a general comment, that it's not. I have to say how policy relevant the stuff that you do are. I mean, it's no doubt in my mind that these are a prime example of immediate policy impact.
Yeah. Mm-hmm. Yeah, no, and it's like informing policy making pretty much in real time. That's how when we started getting all this funding was how can we make this policy useful? It all started as an academic exercise when Jeremy and I started, at least for me, before talking to him, I was like more, I wanted to focus on value of information at that time on our efforts. And instead of building the model, say, you know, this, we could actually be doing more than just like academic exercise, but actually inform policy making. And then the word spread in Mexico and also in California, because that's where we were located. And then we started getting connected with multiple decision makers. And since then, life has been completely different now. But it's always like getting in touch with governors or chiefs of staff or ministries of health from multiple places in Mexico. And so that's been like a fascinating experience that also kind of challenging because it's no longer a model that you put together, you do your analysis and wrap it in a paper and publish it. But here is continuously modifying, of course, the model that we started in March 17th. That's the day we started programming. Until today is completely different model, and then adapting the model based on new evidence and also what are the policy needs and the policy relevant questions that policy makers and decision makers have, and they change quite rapidly over time as well. The policy questions they had in April are different than the ones they have now. So how can we, as academics and also as modelers or decision scientists, can adapt and accommodate their needs to improve the decision making and try to help them make better decisions.
Yeah. So I don't know, since Omar had to go, and I was assigned by him to
close the call.
Any discussion. Do we have any other questions from people? Or should we give Fernando back a portion of his day and let him go with our profound thanks?
Good
job.
No,
thank you, guys.
Great.
And Fernando, before you go, you know what a trick could be to actually do this a calculation for the R?
The RT?
Yeah. I'll tell
one?
you a trick. You put it as an oral, not an oral, a comp exam. You see Mao laughing?
I see. Okay, I see. That's a good one. That's a good one. A pull mechanism, no? You pull the answer from someone that should provide an answer to a posed question.
So good. Then let us thank you once more for a
thank you,
very
Tom,
nice
and
talk.
everyone.
And let's part with this key realization about how policy relevant decision-making analysis are.
Oh yeah, it's been key, I think, these days. Decision scientists have been quite on demand these days to help out in this crazy times. Okay, well, thank you guys a lot, Tom, and all of you. Thank you very much for attending. And talk to you guys soon.
Bye, Fernando.
Bye, Mal.